Let's kick this off by looking at the potential diagnoses that can lead to chest pain. As you can see, there's a lot of things that can cause chest pain, and this doesn't even include all of them. Some of these things are emergent and others are less urgent. Again, it's your job to be able to distinguish between that. So you can see it can be challenging at times to wonder, am I thinking of every potential diagnosis in this patient with chest pain? And even more concerning, am I missing something bad? Well, this video is going to help with that. We're going to talk step by step how to best approach the patient with undifferentiated chest pain. So the first thing you're going to do with any new patient that presents to you, no matter what the chief complaint is a primary survey. So look at the patient's ABCs, their airway, their breathing, their circulation. Does the patient look sick or not sick? For the case of chest pain, you're going to get an immediate EKG on arrival. Obtain the patient's vitals. Make sure to hook up the patient to cardiac monitor, pulse oximetry, and get an IV established. The next thing you can do if time allows and the patient is stable is what's called a chart review. This is reviewing the patient's chart and obtaining more information about that patient prior to going into the room. This can help guide your conversation with the patient and lead you to ask more questions about certain diagnoses. So review the patient's vital signs, their age, their gender, their past medical history. Are they taking any medications? Have they received previous cardiac workup, including EKGs, echocardiogram, cardiac catheterizations? And then take a look, have they been there before for chest pain? And if so, what were they diagnosed with? What tests did they receive? What were the results of those tests? So you can see in 1 or 2 minutes, you can obtain a lot of information about the patient. I will add, make sure to use some caution with chart review. The last thing you want to do is form premature closure or a bias on a certain diagnosis, because that could lead to error or potentially missing something bad. So now that you have performed a primary survey of the patient, along with a chart review, it's time to start thinking about what could be causing their chest pain. And it's okay to start this list early in your head, because you're going to use your history and physical examination, along with the results of your diagnostic workup, to refine and prioritize that list. Now, I developed the 4-2-1 rule to help you remember the main intrathoracic emergent causes to chest pain, because as we saw before, a lot of things can cause chest pain, and some of them are emergent and some are less urgent. And with any patient, you're going to want to first focus on the emergent causes and rule those out, or at least consider them. And this 4-2-1 rule is going to help you remember what those main intrathoracic emergent causes are. I called it the 4-2-1 rule because there are 4 main heart-related emergencies that can lead to chest pain. There are 2 main lung-related emergencies that can lead to chest pain, and there's 1 main esophageal-related emergency that can lead to chest pain. And you can remember this because there are 4 chambers in the heart, 2 lungs in the body, and 1 esophagus in the body. So let's start with the 4 main heart-related emergencies that can lead to chest pain. Acute coronary syndrome, aortic dissection, pericarditis or myocarditis, and pericardial effusion or tamponade. The 2 main lung-related emergencies are pulmonary embolism and pneumothorax. And the 1 main esophageal emergency to remember is esophageal perforation. So I think if you commit this 4-2-1 rule to memory, it's going to help you recall or consider the main intrathoracic emergencies with any patient that presents to you with chest pain. Now, that is not to say that other causes can't become emergent, and there's also extrathoracic emergencies that can lead to chest pain, such as acute cholecystitis or gastric perforation, and those abdominal emergencies will be discussed in future videos. All right, so now we have performed that primary survey on the patient, we've done a chart review, and we've started compiling a list of potential diagnoses that could be leading to their chest pain. We're also keeping in mind the 4-2-1 rule, so that way we consider the main emergencies. Now it's time to start getting that history from the patient. We're going to use that history to help refine and prioritize that long differential in our head. And the first thing I like to do is just let the patient talk. No interruptions. Let the patient share what their complaints are and what their concerns are. Once the patient is done discussing their symptoms, then you can ask more questions to help clarify things or help better differentiate what could be going on. And you can do this in 3 steps. First, focus on the 4-2-1 rule. That way you consider all of those emergencies that we talked about. So ask more questions about each one of those emergencies. For example, acute coronary syndrome. Are they having pain with exertion that improves with rest? Do they have risk factors such as smoking, diabetes, hypertension? Are they compliant with their medications? Do they have a history of acute coronary syndrome? Do they have a history of coronary stents being in place? For example, for pulmonary embolism, you'll screen them for risk factors for that. Do they have history of long travel recently? Do they have history of recent surgery? Do they have unilateral leg swelling or calf tenderness? Are they complaining of hemoptysis? Do they have a history of pulmonary embolism? Are they on hormonal therapy? Now, we're not going to go through every single example, but you can see this is the time to think through that 4-2-1 rule and start asking questions about each one to distinguish, is this something that I need to be worried about? Next, you can perform a general review of systems going through by body part. And you can start with things in the chest first, and then move on to things outside the chest. Don't forget about that. Consider abdominal etiologies that could be causing referred chest pain. Consider things like herpes zoster on the skin that could be causing chest pain. This will help ensure that you think of as many things as possible. So after obtaining a history, you'll perform a thorough physical examination. There's a few things I want to point out because obviously you're going to listen to the heart and lungs. But don't forget to do a few other things. Perform a thorough abdominal exam. That way you don't miss out on abdominal etiologies that could be causing referred pain up to the chest. Take a look at the patient's skin, especially over the area of pain. Do they have any trauma there or any signs of rash or early herpes zoster? You can also assess the patient's pulses and perform a neurological exam. You'll be considering things like aortic dissection when you do that. You can also look at the lower extremities, assess for lower extremity edema or calf tenderness. You'll be considering things like PE when you do that. The next thing we're going to talk about briefly are risk stratification tools that are out there because you might come across them. Just remember that these are tools and guidelines. They are not hard, fast rules to diagnose someone or rule something out. So be careful with that. I link below in the description more information on each one of these assessment tools. I encourage you to go check it out. That way you have a better understanding of this. But briefly, there's the Wells criteria score. This risk stratifies patients for PE. Then there's the PERC rule. If a patient is low risk for PE using Wells criteria and none of the PERC criteria are met, then the patient is considered low enough risk that you could consider not performing any further diagnostic workup for PE. The heart score helps risk stratify patients for ACS, and the TIMI score helps estimate mortality and risk of new or recurrent MI in patients with unstable angina or NSTEMI. Now let's talk about diagnostic workup. Nearly all patients with chest pain should get an EKG and chest x-ray. The higher risk patients are also going to be getting, in addition to the EKG and chest x-ray, some basic labs, troponin, coagulation studies, BMP, and/or D-dimer, whatever you feel is necessary. They may also warrant more advanced imaging, including a CT chest. If you have experience with ultrasound, you can perform a bedside ultrasound to look at overall cardiac function, look for pericardial effusion or tamponade physiology. You could look for a pneumothorax. You could look at the IVC along with other things. And then don't forget about atypical or referred pain. If you're concerned about abdominal etiologies leading to referred pain up into the chest, you might want to consider getting abdominal labs. Also, don't forget about pregnancy tests if that's warranted, and don't forget about things like urinalysis or urine drug screen if that's necessary too. You might also consider other forms of imaging such as upright chest x-ray or abdominal series if you're worried about obstructive pathology or even free air in the abdomen from, let's say, a gastric perforation. You might get a CT abdomen and pelvis, or you might get a right upper quadrant ultrasound to look for hepatobiliary pathology that's leading to the chest pain. If you're worried about things like a AAA, you might consider getting an aortic ultrasound to look for that. The last thing we're going to do to wrap this up is there's a lot of keywords or phrases that are used on board exams or medical exams that when you see them, it should make you associate it with a particular diagnosis. And we're going to go through these. So if there's tearing chest pain radiated into the back or unequal pulses or focal neurological deficits, you're going to want to think about aortic dissection. If the patient has chest pressure, squeezing, crushing chest pain, worse with exertion, improves with rest, radiates to the jaw, shoulder, arms, they have nausea, they have diaphoresis, you're going to think of acute coronary syndrome. If the patient has sharp pleuritic chest pain, pain worse with deep inspiration or cough, recent travel, leg swelling, recent surgery, short of breath, hormonal use, you're going to think about pulmonary embolism. If the question stem talks about a patient with pain worse when lying flat and improves with sitting up or leaning forward, and they had a recent upper respiratory viral illness, they're complaining of pleuritic chest pain, worse with deep inspiration, you're going to think of things like pericarditis or myocarditis. Then if the patient complains of sudden onset shortness of breath, sharp chest pain, recent coughing or trauma or rapid inhalation, consider pneumothorax. If the patient complains of burning chest pain that's worse after eating, consider GERD or peptic ulcer disease. If the patient complains of pain and shortness of breath after vomiting and there's Hammond's crutch on examination, then consider esophageal rupture. If the patient complains of fever, chest pain, shortness of breath, they admit to a history of IV drug use, consider endocarditis. And lastly, if the patient complains of dysphagia, odynophagia, food getting caught or stuck, then consider esophageal etiologies such as achalasia, dysmotility, spasm, or esophagitis.